Hello, it's Bill, the Knee Pain Guru. Today is Wednesday, June 30th, 2021. We're bringing this to you on behalf of the Comella Foundation. It's a nonprofit that helps people with pain as it relates to their bodies. And today we're going to cover the truth about knee cartilage. And I brought a Dr. Charlie Beck, who is also very well versed as far as knee cartilage, on the call today, so we can ask questions, address a lot of the misconstrued information about the what goes on with regenerating knee cartilage. So I'm going to bring Dr. Charlie Beck in.
Hey, Bill.
Dr. Beck.
Good to see you.
Good to see you. I'm glad you're here. I'm glad you can make it.
Thank you.
So I sent you over some questions this morning that gives you an idea of the topic that we're going to cover today. The title of this is The Truth About Knee Cartilage. And what I wanted to do was pick your brain a little bit this morning
Okay,
about
sounds good.
what the deal is, because the storyline out there is knee cartilage can't regenerate. There's nothing anybody can do. Once it wears, once you get arthritis, it's going to be bone on bone. You're going to have a knee replacement. And I wanted to, because you work directly with patients in terms of these types of situations and scenarios, I wanted to get an understanding from your perspective as far as, what the deal is with all of it.
Perfect.
So before we get into it, could you share your background, like that you're just not some guy off the internet? Can you share? Because I know you have quite a resume, and if you share a little bit.
So let's start with background in engineering. So my brain works like an engineer. I want to understand how and why in a way that makes rational sense, at least to me, and also in a way that allows something to be done to change whatever the situation is. My medical school background, I went to osteopathic school in Pikeville, Kentucky, and learned under Ed Stiles. It was kind of a perfect storm for learning. Ed's one of the best manipulators in the world, and in my opinion, also one of the best teachers that I've ever been able to spend time with. And I spent an extra year undergraduate and what they call an undergraduate fellowship. So I spent an extra year learning about osteopathy. Then came out, did my internship and residency at Westview Hospital here in Indianapolis. And my residency is in neuromusculoskeletal medicine, which up until last year was unique to the osteopathic profession. So the MDs don't have it. They don't think that way. The chiropractors don't have it. And because in the US, we're the only country where being an osteopath means that you're a physician, no other country in the world, again, thinks like we do. And so then after doing my residency, took more specialized training, wound up getting my fellowship in the American Academy of Osteopathy, and there's about 85 or 86 of us in the world. And then my training also took me into learning how to prescribe eyeglasses, learning about prolotherapy. There were a number of my patients who were not getting better despite everything that I tried. And prolotherapy got a huge chunk of them improved. So I've been doing prolotherapy for, probably close to 15 years now.
Got it. Okay. Awesome. Thank you. So the context for this is what I share with listeners on the internet, on my YouTube channel, is that I approach it with 3 steps in terms of knee pain. We're looking in the context of knee pain. First is get the pressure off of the nerves in the knee that are causing the pain.
Okay.
shift the neurological signaling from a sympathetic to a parasympathetic state, which sets up the conditions for the body to begin to heal itself. Then we got to create the environment in the body: water, nutrition, breathing, supplementation, mindset, stretching, mobility. And I refer to them as pain pattern interrupts. So that is, so pain pattern interrupts, we can talk about it as orthobiotomy self-care. We could talk about it as osteopathic manual manipulation. I'm essentially teaching clients how to do this for themselves.
Absolutely.
So in that context, now we've gotten the pressure off of the nerves. We've created comfort in the knee, reestablishing the tensegrity of the knee joint. We are setting up the conditions, doing whatever the body needs in order to begin to heal the joint, and then look at mindset that you're not going to go back and do the thing that got you in pain to begin with. So that's my 3-step process.
Absolutely. Makes sense.
Okay. So on the topic of cartilage degeneration, regeneration, it all applies from my perspective, my approach. We got some pushback from people who don't believe cartilage can regenerate. And that's why I wanted to bring you on the call today, because I'm going to hit a ceiling. What I'm able to help clients with remotely, what I'm able to do, those things, I hit a glass ceiling. Things are above my pay grade. I am not oblivious to that. And there are other elements that can be brought into that existing equation that can set up the cartilage in the knee to begin to regenerate.
Okay.
Great. Take it away.
Okay, I'll take it away, and I'll try to make everything fit together so that the people that are listening get a better understanding of how the body and specifically the knee is supposed to work. Okay. So let's start with tensegrity. It is a term that was coined by R. Buckminster Fuller, same guy that gave us buckyballs and geodesic domes. Mm-hmm. And it is a combination of the words tensional and integrity. And it's an architectural term. So for the longest time, it wasn't applied to the body. But basically what we're taught is if we look at, for example, a brick buildings can be built safely about 3 stories tall. You literally walk into any old town, America, downtown, the brick buildings are 3 stories tall. Because once you get past that, making a wall that will support the weight of the bricks on top of it becomes challenging. Okay. So that was the architectural thinking of the time. Bring in tensegrity. Tensegrity structures can literally reach the moon. So it's a different thinking. Tensegrity structures are self-supporting, and that is the key. When we think about the body with what I'm assuming that everybody here is old enough to have gone through elementary school, high school, college. Mm-hmm. But when we were taught that gravity works on the body. And when you look through the people that are teaching about posture and everything else, gravity is a bad thing because gravity negatively influences the body. From the aspect of tensegrity, the only time gravity negatively impacts the body is if your tensegrity structure isn't working correctly. Mm-hmm. If your body is working correctly within the tensegrity system, it is self-supporting. It is an anti-gravity device. Mm-hmm. Now, I don't tell my patients this. I just come in and treat them. And it is not quite universal, but very, very common that people say at the end, I feel lighter, I feel taller. Mm-hmm. And I didn't stretch them. I didn't put them on a medieval rack and make them that way. But I got the tensegrity system restored. Okay, so now I'm going to apply that to the knee. In a tensegrity system, the more you load the knee with axial forces, the more the knee joint separates. Okay, I will repeat that again and again and again, because until you understand it, healing the knee doesn't make any sense.
Mm-hmm.
So the more you load the joint, that is to say, if I climbed on your back
Right.
and you could support my weight, what happens in the knee is that the joint actually gets more space between the tibia and the fibula. Okay.
As long as the tensegrity structure is established.
Correct. As long as it's working correctly.
Okay.
All right. So what that means, first of all, is that by definition, if we're adhering to tensegrity, and there have been lots of articles that prove that it works. Donald Ingber is the foremost expert in the world on the cellular tensegrity and how it works in the body. He wrote a paper that came out in Nature in 1999. Okay, so we theoretically have been bathed in tensegrity knowledge-wise for at least 22 years. Mm-hmm. So if your tensegrity structure is working correctly, you cannot get knee degeneration. Can't. And so when you look at a cross section of the population, you're going to have some people who wind up with no knee pain their entire life. Knees are healthy. They die with the ones that they're born with, and they never have any problems. You're going to get other people who perhaps at a very young age, because their tensegrity structure is not working, have knee degeneration. And then they need help. Okay. I'm now going to take that and set that aside. That's tensegrity. Mm-hmm. And we're going to talk about fractal physiology. Okay. So fractals are simply repeating structures in nature. That's all they are. There is, again, relatively new movement. It wasn't around in the 1800s. It wasn't around in the 1950s. But our understanding about how the joints move in the body. So we call the knee a hinge joint. Mm-hmm. Making us think that we could look at our door, the nearest door, look at that hinge, and by watching the door hinge move, also understand how the knee moves. Mm-hmm. And it's actually kind of a misnomer, because if you look at fractal physiology, the knee joint, again, if it's working correctly, never moves the same way twice. It'll go through the same patterns of motion, but in a different way. Mm-hmm. So now if we have the knee joint itself, which is unloaded because tensegrity is working, and we're never technically moving over the same cells over and over again because of fractal physiology, we have a knee that can stay healthy into old age. Mm-hmm. Okay. Now, I was taught this in medical school, but only because the guy teaching me was one of the forerunners bringing tensegrity to the medical world. Mm-hmm. That's the only way that I know about it. Otherwise, I'd go through my whole life and be ignorant of that. From an engineering standpoint, it begins to lay the groundwork for why people can get knee pain. And if they get knee pain, what's going on behind the scenes that basically, I'm going to say very few people in the medical community are looking for. Mm-hmm. So, for example, if you get a knee replacement, it does not fix your tensegrity by definition. You just have a knee replacement. And so, I mean, if we take the recent tragedy in Florida into perspective, if you took a building that was about to collapse and you had, let's say, a dozen columns that were bad and you replaced one of them, it doesn't fix the other 11. You still have issues. Okay. Right. So with fractal physiology in place and tensegrity in place, when we approach the knee, looking at the way that you have set things up with your clients, what we're also looking to do is not only take the load off the nerves, which are sending the signal, and restore as much motion as we can in the knee, but we'd love to figure out how to get the whole body to work better in its tensegrity system so that you get the body supporting the knee and the knee not trying to act alone. Mm-hmm. Okay, clear as mud?
Yeah, well, yeah, it makes sense. We're reestablishing the tension. I talk about the body as a series of pulleys and levers. And when that gets compromised from an accident, an injury, a surgery, a trauma, whatever is going on in the body, that tension is now not balanced in a way that irritates the nerves. And by creating comfort, getting the pressure off of the nerves, we switch the neurological states, the body begins to reorganize, and we become aware of tension in other areas of the body that we can begin to address.
Mm-hmm.
So that's the approach. I mean, you're going into it, you're describing it in a much more scientific, medical way, engineering way of understanding what I'm trying to dumb down and make it simple for someone who's not familiar to get. That is coming off the internet, seeing this around the world and going, oh, that makes sense. Create comfort, set up the conditions so the body can heal itself, avoid self-sabotage that puts you back into the place.
Correct.
That you were in pain to begin with. So now, when we initially spoke about doing this interview, you broke it down into, for simplicity's sake, 2 categories. You had minor cartilage degeneration, major cartilage degeneration, or bone on bone, severe osteoarthritis kind of situation.
Right.
Would you go over your strategy as far as how that would look when you treat a patient?
Okay. So first of all, I have to describe the parameters that I'm looking for. Mm-hmm. People come to me because they're in pain. Mm-hmm. Just like the reason that they would be on the Knee Pain Guru website.
Right.
So I am looking for a resolution of pain. I am not necessarily looking for perfect x-rays, regardless of whether the pain is there or not. Mm-hmm. If I can get you out of pain, get you to be able to live with the knees that God gave you for the rest of your time on the planet, in my mind, we have succeeded. Okay. Right. So just got to be clear about that. Also, go ahead.
If I can interrupt you there for a second, this is where a lot of people get stuck. They get stuck in, I got to regenerate the cartilage in my knee.
Correct.
They get stuck in that mentality. They got the doctor's diagnosis, and their mind goes, well, my knee pain will go away if I regenerate the cartilage in my knee. And I'm trying to take that attention off of that focus and put it exactly what you just said. If the knee is comfortable, you have full range of motion in the joint, and you're enjoying your life, do you really care what the x-ray, the CT scan, or the MRI says? Do you really care what the diagnosis is?
Correct.
Okay. I'm sorry. I didn't mean to
That's okay. Let's get clear about arthritis.
Mm-hmm.
Okay. Arthritis is something that a radiologist diagnoses. That's it. When you look at a joint, the surface of the joint is no longer smooth. You have a diagnosis of arthritis. Okay. Mm-hmm. That diagnosis in no way, shape, or form is linked to pain. They are separate. You may have pain and you have arthritis. Okay. But arthritis, by definition, does not cause pain. And so what happens is patients come in to see me, clients come to see you, and many other people around the world with a diagnosis of arthritis. Well, if you get their pain to go away in an office visit, 20 minutes, 30 minutes, an hour, whatever it is, you didn't change their arthritis. The arthritis is still there. Mm-hmm. But what you proved is that the arthritis is not causing the pain. Mm-hmm. Okay. Now, so we have to go back and look at some more science to understand how these things happen. Mm-hmm. And not an exhaustive list, but basically here's what can cause a change in the joint surface. We already covered tensegrity. Okay. Mm-hmm. An active infection can cause a change in the joint surface. So, for example, you go stick a rose thorn, just so happens right into your knee joint. You pull the rose thorn out. You didn't know the rose thorn had some bacteria on it. You're going to get a very red, very painful, very swollen, and because there's swelling and all kinds of infection going on in the knee, very arthritic knee. Mm-hmm. If we can get that settled down with antibiotics and we don't have to do surgery, now you have degenerative changes in the joint because of an infection. Okay. Again, that doesn't necessarily equate to pain. Okay. The biggest thing that people are not aware of, and honest to God, because I teach doctors, I ask them the question, who knows about Wolff's Law? And no hands go up.
Okay.
Okay. So Wolff's Law, and in biology, a law means since its inception, no one has ever been able to prove it wrong. They've tried. Now, we don't know if it's right, but we can't prove it wrong. Okay. Gravity is one of those things. We don't know that gravity exists because on this planet, we can't set up a lasting experiment without gravity to prove that gravity exists. Okay. We can get moments of it when we go up in an airplane and start flying downward. We can fly toward the ceiling, but we can't immediately reestablish gravity and make it go away. So we can't do real science around it. Okay. So these are laws that we haven't been able to prove that they are incorrect. And Wolff's Law says a tissue will grow based upon the forces placed upon it. Okay, so if we talk about anyone out there and I say, hey, I want you to be a power lifter. Tomorrow, I want you to lift 500 pounds in a bench press. Most of your viewers are going to say, yeah, that's not right. Can't do that. We'll never be able to do that. But Wolff's Law says differently. So tomorrow, people might go out and they might be able to lift the bar, 45 or 50 pounds. Almost anyone could do that. But they can't lift more than that. But they keep working with the bar. And what happens is muscles grow. Bones get thicker. And so over time, they can lift more than the bar. And the more they continue to do it, the stronger their body grows. Okay, that is Wolff's Law in action. Bone spurs. Wolff's Law in action. There is tension on the bone, and the bone grows based upon the tension placed upon it. In medical school, they didn't teach us to look for the cause of the tension. You cut out the bone spur, right? So that's not good engineering. You want to know why it happened so you can prevent it from happening again. If we look at fingers and knees, that tensegrity structure, when it fails and the joint gets pushed together because it's no longer being supported,
right?
The body says, oh, I know how to fix this. I know how to guarantee that I have mobility because my joint's being pushed together. I can remodel the joint. And so you wind up with arthritis because of Wolff's Law. Okay. So have to understand Wolff's Law. And I could go in, I could speak for hours and hours and hours on the ramifications of not understanding Wolff's Law in the body. But what I want to reiterate there is that arthritis does not equal pain. Okay. Arthritis is something you find on an x-ray. When we talk about the knee, you cannot individually see cartilage on an x-ray. You see the bone, and the bone is smooth or the bone is rough. You see the joint space, and the joint space is normal, meaning your tensegrity structure is in place, or the joint space is abnormal, meaning that the joint space is not tensegrity supported. And because of that, you have a wear pattern that is beginning. Okay, does that make sense?
Yes.
If that wear pattern continues, you will theoretically wear all the way down to bone. You will wear through the cartilage because it cannot replace itself enough. Okay. So if we go back and look at the system, I'm trying to answer the question of the people out there that are the naysayers. If you have a system that is constantly under friction, the body will not heal itself. Think about a cut on your arm or your leg. If you continue to rub on it, your body cannot regenerate that tissue. So I remember my mother at least saying, we put a Band-Aid on it, stop playing with it, let it heal.
Right.
It's really similar everywhere in the body. You've got to give in the case of the knee, you got to offload the tension, and you have to let the body do everything that it can to heal.
So the offloading the tension looks like working with the intrinsic movement of the joint
Yes.
to reestablish the tensegrity structure in the joint, which gets the pressure off of the nerves, allowing space to be reestablished within the joint.
Correct.
Okay.
That's what we do. Okay. And I'm going to kind of put in the caveat that that's people whose damage is light to medium, let's say, for example. Okay. Someone who has major damage, they're going to need more help than that. We can establish their tensegrity system, but their body has adapted in such a way that it is very hard for it to be completely self-supporting from that point forward.
Right.
Okay. Without some major healing. So the orthopedists use this thing called an offloading brace. Basically, it grabs the upper and lower parts of the knee, and you can move that tissue, the fascia in this case, and take some weight off of the knee. Okay. And so if we understand that from an engineering standpoint, we could use an offloading brace therapeutically to help our patients heal more.
So one of the pieces that I'm seeing in our conversation today, where there are gaps in awareness for people that are coming off the internet, they're looking at, one, knee cartilage can never regenerate because they don't understand the concept of tensegrity structure and reestablishing that in the joint.
Correct.
That's one piece. There's another piece where people will go to the doctor and they will get an offloading brace, but they've not done anything as far as the tensegrity structure to rebalance the tension. So when they take the offloading brace off, that the body doesn't collapse back to the place that it was before they put the offloading brace on.
Correct.
Okay.
And one of the things I tell my patients is, if you drive your car and your car is has a bad front end alignment, okay, what we know is that will put premature wear on your tires.
Right.
Giving you a new set of tires doesn't fix the underlying problem. We have to align the car, then make sure your tires are safe to drive on, perhaps giving you a new pair, and then we've corrected the issue.
Right. The last piece that I see in that equation that we spoke about on our initial conversation, and I'd like to take a moment. We have a number of people that are watching the live stream today. If you have questions, you would like to ask questions about your knee, cartilage, knee cartilage, doctor, any of the stuff that we're talking about today, please type those in the comments section. We're streaming live on both YouTube and Facebook as well. So the piece that I wanted to talk about is prolotherapy and how that can be brought into this equation, both with mild to medium cartilage degeneration, as well as severe cartilage degeneration used in conjunction with an offloading brace.
Okay. All right. So let's start with history. My understanding is that prolotherapy started with Socrates. And what happened is, at the time, the javelin throwers got injured shoulders. We would probably now call that a rotator cuff injury. And they would literally take a hot piece of iron out of the fire and stick it through the skin into the person's shoulder. And that was original prolotherapy. Okay. Now, and what it did is it would cause scarring of the tissue. So if you had something torn, and you could get really specific, painful, but it might be a way that got you some freedom of motion. Okay. Nowadays, George Hackett, who was an MD, came up with a way to help his patients. So we started off with rabbits. And what's interesting is we live in a society now where the things that happened in the past wouldn't happen again because we can't go back and recreate them. Okay. The ASPCA would be all over George Hackett for what he did in the 70s.
Okay.
But he took sugar, literally dextrose, and injected it into one of the back legs of a rabbit. And then about 6 to 8 weeks later, he sacrificed the rabbit. He wanted to see what happened. And the side that he injected, the tendon was twice as big.
Okay.
Okay. So from an engineering standpoint, that means 4 times as strong.
Okay.
And he thought, oh, okay, curious. He repeated the experiment a couple of times, proved that it was pretty consistent. And then he started working with different solutions and working with his patients.
Mm-hmm.
So what came out of that was proliferative therapy. That's what he called it. To proliferate means to grow.
Mm-hmm.
That got shortened into prolotherapy.
Mm-hmm.
Okay. So out of George Hackett's work came the Hackett Hemwell Foundation. Mm-hmm. And they're based out of Wisconsin. They teach classes multiple times a year. They set up mission trips to different countries, and people go in, and folks come from all around just to get prolotherapy done for a solid week. Mm-hmm. They were the beginning of prolotherapy. Okay. And I've been to the Hackett Hemwell Foundation a couple times, know a bunch of their members. Wonderful organization that really doesn't understand tensegrity.
Okay.
Because tensegrity was not a big thing when George Hackett was doing his work. Okay. Mm-hmm. Now, they may go through and find that they have fixed tensegrity by doing an injection, but they're not looking for it. Mm-hmm. Okay. So there's just a difference there.
Sure.
When it comes to being, and I'm going to say taking the more allopathic approach, when you make a solution, the solution is always the same. Mm-hmm. The needle goes into what's called the enthesis, which is the connection between the bone and the tendon or the ligament or the cartilage.
Okay.
And at that enthesis, you put in your solution. Mm-hmm. Okay. When you start to recognize that what you're doing is you're treating connective tissue, mm-hmm. if you can prove to yourself where the needle is, you can treat fascia.
Okay.
Because it's connective tissue.
Right.
Okay. So prolotherapy has applications almost anywhere in the body. The principles behind prolotherapy have application everywhere in the body. Mm-hmm. Okay. So our principle is we're going to use an irritant, and there are almost as many different solutions as there are people who are doing prolotherapy. Mm-hmm. If you and I were doing it, my solution might be a little bit different than yours. Mm-hmm. And so when you start to look at that, you realize it probably isn't the solution itself. So it's the principle behind what the solution does. And we use sugar primarily dextrose. You can use other sugars like mannitol if you wanted to. Mm-hmm. But the dextrose concentration is what makes the difference. So at a low concentration of 5%, and for people who, for example, watch the show Squad 51 back in the 70s and 80s, often they would use D5W, which is 5% dextrose in water. Mm-hmm. That solution for the body is nutritive. We can give it to you in an IV and feed your cells. Mm-hmm. If we give you a solution that's higher in sugar, then the body doesn't see it as nutritive anymore. It sees it as an irritant. And if we give you a very high concentration, it kills the cells.
Okay.
So part of it is understanding the concentration gradient of sugar and what it does within the body.
Okay.
Primarily for prolotherapy, you're using a 15 to 17% sugar solution. Mm-hmm. That is an irritant that causes the cells to, and I'm going to keep it simple and just say get irritated. Okay. Mm-hmm. So if we look at an injury in the body, this is the way it was explained to me that makes the most sense. So, and we'll keep it with knees. Okay. Bill, today, if you fell down, hurt your knee, doesn't matter what the injury is. Mm-hmm. Your body is going to call out the repair crew. So it sends a work order to the brain. Hey, this happened. Please send the repair crew. And that means that your repair crew has to have enough basic building blocks to be able to repair. It has to have enough water. It has to have enough energy, and it can't get called out on another job. Okay. So it has to be able to go in and do everything that it needs to in one swoop, and then it's done. If you don't have enough water, if you don't have enough basic building blocks, the repair crew gets sent back, and really your brain doesn't send out another repair crew.
Mm-hmm.
So whatever healing was accomplished is it.
Mm-hmm.
With prolotherapy, you can send out another repair crew, very specifically because they really only go where the solution goes.
Mm-hmm.
So I can continue to injure you over and over, very, very specifically and very lightly, until the healing has reached 100%.
Got it.
Okay. And that's the idea behind prolotherapy.
Mm-hmm.
If we're dealing with the knee, I'm going to add a twist in here, and we're looking at cartilage. Cartilage is richly innervated. It's got lots of nerve endings, but after it finishes growing when we're very, very young, it has a poor vascular supply. Mm-hmm. So cartilage heals slowly. Mm-hmm. Okay. And that's the key, slowly, unless you can do something to supercharge it and spur the healing on, which is to use something like ozone. So ozone is, like when we use it in a syringe medically, about 99.5% oxygen and something less than 0.5% ozone. Mm-hmm. Here's the thing. I'm putting oxygen around a tissue that is poorly oxygenated. Mm-hmm. So I can spur the healing on more rapidly.
So this is ozone that also has the dextrose in it that is going at the specific site of where we're looking to promote the healing of the cartilage?
I'm going to say yes and no.
Okay.
The ozone is a gas. I can't put a liquid in a gas.
Okay.
So, but from our standpoint, we use two syringes. One syringe would have the liquid.
Okay.
One syringe would have the gas.
Got it.
Yes.
Okay. Oh, okay. So now we have, we're using that I would say it, and I don't want to do a broad brush, but would you say in your treatment of patients, are you more in the minority or the majority that is using ozone in conjunction with the prolotherapy to regenerate knee cartilage?
Okay. Of the physicians who use prolotherapy,
yes,
there is a smaller subset that use prolotherapy with ozone.
Okay.
Okay. And that's
okay.
It.
So we have all doctors, all physicians that use prolotherapy. And
Correct.
Then there's a portion of those that use prolotherapy in conjunction with ozone.
Correct.
And then you even have a smaller subsection that use prolotherapy and ozone reestablishing the tensegrity structure.
Yes, a very small subset.
And then you even have a smaller subset that would use the prolotherapy, the ozone, reestablishing the tensegrity structure, and using an offloader brace as a strategy for the body to heal severe arthritis.
Correct.
Okay. So regenerating knee cartilage is absolutely possible. It's just that you have to look at the tools that you're using. Yes. You have to look at all of those components to set up the right conditions so the body is able to heal itself.
Yes. Yes.
Okay.
And I would say from a physician standpoint, you have to be willing to continue to learn. Because what you do for one patient, you might do the same thing for the second patient, and the second patient doesn't get well.
Right.
And it doesn't necessarily mean that you've done your job wrong. It just means that you didn't understand that second patient's issue well enough to give their body what it needed.
Right.
So there is, theoretically for all of us, there should be continual growth, learning from our patients how to better serve them.
Right. I refer to it as the pivot. Okay, try this. Let's see what happens. Give me feedback. and let's see how we need to shift and change or adjust what we tried based on your participation and your awareness in your own healing process. So now we know how to move forward from there.
Yes. Yes.
Okay. We have a few questions coming in from those that are watching. One is from Kathy. She is actually in Knee Club. That is one of the. Let me see. Oh, is that okay? The question is, I don't know if it's actually showing on the screen.
Yep, I see it.
Okay. It says, what would cause knees to have severe cartilage wear on the inside portion of the knee only?
Okay. It's a long answer, and I'm going to try to make it simple. So within osteopathy, what we learn is that trauma causes regression along embryologic lines. Okay. So what that basically means is that the more trauma you have, the more your body goes back to how it was when it was younger.
Mm-hmm.
And we see that in psychology, people who have, to quote a World War I term, shell shock, can get traumatized enough that they lose their ability to speak. They become catatonic. Okay.
Mm-hmm.
But the same thing happens everywhere in the body.
Mm-hmm.
So I'm going to make sure you can see my hands. When you're growing inside mom, your feet start this way. Okay, let's see here. There we go.
Yep.
And as you grow, your feet do this. They become flat. All right.
Okay.
There is a reflex named after a person. It's called the Babinski reflex.
Mm-hmm.
Not to be confused with the Babinski sign. Babinski sign is a bad neurological finding. The Babinski reflex means that your foot went from being flat to where you're walking on the outside of your foot. Okay. So that is a Babinski reflex. You went backwards in time a little bit, and your body can't put the foot flat anymore. It only goes to the outside.
Mm-hmm.
Okay. So when you go to the outside, the thing that you may notice as a client is that the outsides of your shoes wear a little more than the insides.
Mm-hmm.
But what happens is when the weight goes to the outside of the foot, the body stabilizes that by pushing the knees outward,
Mm-hmm.
which then puts the force on the inside of the knees and the wear on the inside of the knees.
Mm-hmm.
Now, only because I teach courses on primitive reflexes do I have any clue about that.
Right.
So your orthopedist isn't going to know for the most part. Your podiatrist isn't going to know because they aren't taught in school.
Mm-hmm.
Only if you have a class in retained reflexes are you going to put those things together. And so that reflex is like a virus in your computer software.
Mm-hmm.
It's always there no matter what's going on. And you can't think your way out of it.
Mm-hmm.
So the reflex always kind of takes precedence if it's present.
Mm-hmm.
Okay. And so for me, fixing that cartilage wear on the inside of the knee would be treating the reflex or reflexes until the foot can go flat again,
Mm-hmm.
thus offloading the inside of the knee.
Mm-hmm.
Then we can work on healing the knee.
Got it. So Kathy, I've gone over these reflexes with Dr. Beck previously. So I have a list of those. We will address those on the next Knee Club call. Those are the ones that we went over around with Evie. So, yeah. So awesome. Did you have anything else that you wanted to?
That's it for that question.
Okay. Sushma Kaul said, how can I regenerate knee cartilage? It looks like you need to go back and watch the beginning of the video when we're done. Let's see. Julie says, what about Baker cysts? And I have, I've gotten great success with working with clients with Baker cysts. It's from my perspective, we're reestablishing the tensegrity structure. We balance the pelvis, and a lot of times the Baker cyst begins to resolve itself in a relatively short period of time. Dr. Beck, do you have anything to add to that equation?
No. Baker cysts are most often mechanically triggered.
Mm-hmm.
Something's not right in the knee, and the knee, in order to protect its structures, forms the cyst.
Mm-hmm.
So if you can get the whatever's not right in the body to go back to normal,
mm-hmm.
the knee no longer needs to protect itself, and the cyst begins to shrink.
Right. Yeah, I find that, like, the longer we've known each other for decades now, and I just find it, the more I've learned, the more I study, it just gets simpler and simpler. Can you say something contrary to that? I mean, we go deeper when we talk about fractals, those patterns.
Right.
Nature. You go deeper, and it's like the more simple, the more we get to the crux of the issue by getting the pressure off of the nerves, by reestablishing a tensegrity structure, set up the conditions so the body is able to heal itself and avoid self-sabotage.
Yep.
Body heals.
Yes.
Now we can get into all of the nuances and the specifics of that, but there is essentially a very, very simple process by which the body heals.
Yes, and it's principle-based.
Yes. I'm going to go over, I sent you the questions that came in. I'm going to scan over those a little bit. I don't want to go in too deep.
Gotcha.
We've kept the video pretty PG so far.
Yes.
So this was from Alan. Alan was asking how many of your patients have regrown knee cartilage as evidenced by before and after x-rays through your approach. You had covered that arthritis is going to exist
right
before and after, and it's not a function of pain.
Yeah. So, I get people that come in with bunions and their bunions hurt. Well, first of all, let me just be clear. I'm not a surgeon. I'm going to look at your feet, and if your feet are pain-free and you can use them for the rest of your life, if you have a deformed toe, but you can work with it, totally fine by me.
Mm-hmm.
But what's interesting is society seems to think your body needs to look perfect, no matter if you're in pain or not. It's the looking perfect that's important. And that isn't reality.
Mm-hmm. Yeah, I get that. X-ray evidence. You have patients to support this claim. If you make the claim, science doesn't recognize it. See, all of this, once again, this gets off track. I focus on working with my clients, and this is another one of his questions. How many patients? I don't see patients. You see patients. I see clients.
Correct.
That I focus on getting them comfortable. I focus on teaching them how they can create comfort for themselves in their knee, their hips, their lower back, wherever it is in their body. And then we're having a different conversation because they're enjoying their life and they're doing their thing.
Correct.
Let's see. If you make that claim, which science doesn't recognize is true? You must have this kind of x-ray evidence to back it up. You agree, don't you? Leading question, not really applicable. How do you prove tension in the body is causing loss of cartilage in the knee? We covered that as far as the collapsing of the tensegrity structure. Doesn't seem to be provable. Do you have reference from people with bone-on-bone arthritis of the knee who claim that you eliminated their pain? Yes, I have many. It's like it isn't a function of the diagnosis or what it looks like on an x-ray, CT scan, or MRI. Oats Therapy. Could you speak to that a little bit? Because I know they're taking a plug of cartilage in a part of the less weight-bearing part of the knee, and they're putting it in the knee.
Well, wait. So hold on, because I read that.
Yes.
and the cartilage cells spread. That's what the message said. You put the plug in and the plug spreads the cartilage cells.
Okay.
Okay. For the same person who said cartilage cells don't regenerate.
Well,
I mean,
and the interesting piece, and I don't know if you touch on this in your practice, but I get into the psychology of how pain affects how people think. And they think differently, they feel differently about their body, and they process information very differently because it's not clear. There's a layer and levels of trauma that's going on that obscures their logical thought processes.
Yep.
So I
that's
think
the regression.
Yeah. Okay, great. Perfect. Thanks for tying that in. And then I think he had 2 accounts. The importance of drinking water, which I've heard from other sources, stopping the actions that are causing the pain and speeding up the process of joint degeneration is obvious. What every doctor, physical therapist tells you. So it all comes down to references, and you should have many, many of them to support the claims you're making, which no doctor or scientist believes is true.
I'll address that.
Okay.
I'll try to keep it PG.
Okay.
So I'm just going to use an article that I read recently, and it was about osteopathic manipulation and treating headaches post-concussion.
Okay.
So the authors put together a study where, now keep in mind, this is headaches. We're treating the head and post-concussion, which the brain moves around inside the head. So the author said, well, we won't ever touch the head. We won't ever diagnose the head. We won't ever treat the head. We will treat the rest of the body in a random order, and we'll see if it helps headaches. Okay. Now, I mean, pardon my French here, but my bullshit meter pegged, because if you take your car into the mechanic with an engine problem, and they put a new ladder in your trunk, and they put a new quarter panel on, and they change the cabin air filter, would you expect it to do anything different? And the answer, of course, for your car is no. So when you look at the studies that are out there, and it's especially big in the age of the thing that the world is going through, where science has been thrown out and it's now politics. When you look at the science, you have to understand more than the person doing the study to figure out if it was actually a good study or not. I haven't read a good study in years, because now what happens is people will do something to advance their agenda. Okay? So I'm going to go back, and I'm going to speak about what I see in my practice. Patients will come in and say, I went to physical therapy for 6 months, did everything religiously, no help. 30 minutes after I put my hands on them, they say, wow, I got further in 30 minutes than I did in 6 months. This is not to say that there aren't good physical therapists out there, but if the thought process behind it is incorrect, it's unlikely to work. Okay. Surgeons, orthopedic surgeons, make money doing surgery.
Right.
They don't really make money doing prolotherapy.
Right.
So why in the world would they support it?
Yeah. If you give a kid a hammer, everything's a nail.
Correct.
Yeah.
Correct. And it's not to say that orthopedic surgery isn't important, because it is when you need it.
Sure. Yeah.
But you can't look to the orthopedic community to prove something they don't do. And what's interesting is I find this often. So I'm a clinician, okay? I do studies for myself on my patients to prove what's theoretically working or not. Once it starts working for me fairly consistently, I stop looking. I found a tool that seems to work. But it's not my job to prove it to the rest of the world. It's my job to help my patients get better. And so typically what happens is the gurus are the ones you never hear about unless you are their patient.
Mm-hmm.
It's the non-gurus that are trying to advance their name.
Right. So, New York guy writes, it's disappointing that you double down on claiming that cartilage can regenerate when it really can't. If anybody could do this for a patient, they would become rich overnight. Has it happened, Charlie?
Are
you rich yet?
No. Well, rich in many ways, but financially,
yes. Abundant. Okay.
Correct.
There are millions of people all over the world who would want that procedure or that therapy or that drug. So you're lying to the public and equivocating. So,
okay. My response to those folks is you are so welcome to come spend a day in my office.
Yeah.
I will show it to you right in front of your eyes, and you can make up your own mind at the end.
Mm-hmm. Yeah. Oh, yeah. I got one more.
Okay.
Giovanni writes, I took an x-ray. My femur and tibia bone are crooked and misaligned in my x-ray, and I'm going to have a knee replacement because I don't think there's any way to straighten it up. Do you have any ideas that you have ever seen it work straightening up the crooked finger bone in tedious?
I'm assuming that's femur.
Sometimes
I'm assuming
spell check and things like that can make communication over the internet a little challenging. Anyhow,
so if we go back to reflexes,
yes,
and I'm going to try to keep it simple. Mm-hmm. If we look at how you are standing over your feet, mm-hmm. your eyes have an influence on it. So whether you have glasses or not, but if you have glasses, whether you have the correct prescription and whether they're aligned correctly to your face. Mm-hmm. Your ears, so your vestibular system, also has a role to play. Mm-hmm. Your teeth have a role to play. Your tongue has a role to play. Mm-hmm. All of those can literally influence your posture in dramatic ways. Mm-hmm. Trauma, so something that twists your body, can play a huge role in how you're able to stand over your feet. And anything that goes on in the pelvis. So he asked a question which has a very complicated answer, yet the principles behind figuring out what's going on with that particular person are pretty simple and straightforward.
Right. Create comfort by getting the pressure off of the nerves in the knee, setting up the conditions so the body's able to heal itself, avoiding self-sabotage.
Right.
I get it. Let's see. We had another question come in. Let's see. Kathy writes, does Dr. Beck know any osteopathic doctors he can recommend in Connecticut to do Prolotherapy?
Let me.
Now. Oh, yeah. She did say osteopathic doctors. And once again, Kathy, we've got layers that they're doing, the Prolotherapy. They were using ozone because that enhances the process. Maybe I think Kathy has an offloader brace. I think we had that conversation around that. And then the work that her and I are doing are reestablishing the tensegrity structure in the joint.
Okay. Wait, how does that work? Oh, that's from me. Okay. So there's Perretz, Perretz, and Paul Tortland, both of whom are in Connecticut, it looks like. If you go to the website called getprolo.com, that should take care of it.
Getprolo.com. I'm sending that out in a little. Yeah. Okay, I sent that out. That's in there. Okay.
Cool.
I think we covered everything.
That's awesome. Thank you, Bill.
Thank you, Dr. Beck. I really appreciate your time. I will have this posted both on the Comella Foundation website, which is the nonprofit that Dr. Beck and I work in conjunction with. We'll also have this on the Knee Pain Guru website, as I believe this information is valuable for anybody that's suffering in pain. Let's see, let's get them the information. They can go to the ComellaFoundation.org, and then also, make sure to give the video a thumbs up, like and subscribe to the channel, turn on notifications for videos, share this video with your friends, especially the ones that limp. They're easy to spot. Dr. Beck, Charlie, my good friend, my brother, it's been a pleasure.
It's been fun. Thanks, Bill.
Okay. Thank you so much, Charlie. Have a great day.
Okay.
Bye-bye.